webinar series. As you all know that we have these webinar series on promoting health throughout the life course during COVID-19 pandemic. This we started, and today I'm very happy that we are almost halfway through. We are on the fifth webinar of the series, and a very important one which cuts across many other areas of work. So today's webinar is task sharing to maintain sexual services during COVID-19. So this is our fifth webinar, as I said. As you all understand and know that health workforce is one of the very important pillars of our health system. So whether we talk about doctors, nurses, midwives, paramedical workers, frontline health workers, all are very, very important for you, for all of us, especially during COVID times. We see that health workforce is playing a very, very important role. And a lot of health workforce has been repurposed to support COVID-19. So we, as WHO estimates, that there is likely to be a shortfall of 18 million health workers by 2030, mostly in middle and low income countries. And health workforce has a very vital role in building the resilience of the community, the health systems, respond to disasters of various natures, whether natural or man-made, environment, ecological and biological, and also now the pandemic. First WHO task shifting guidelines were prepared in 2008 with special focus on managing HIV/AIDS. And then it was followed by in the area of family planning and comprehensive abortion care. Shift for task sharing should be implemented with various other strategies to improve specific skills of service providers to increase the number and across to the access to the health services. In Southeast Asia region, countries have implemented task sharing, task shifting, whatever you want to call it, guidelines, and designed various in-service trainings to standardize the skills of service providers. Today, we will be also highlighting Bangladesh and Nepal experience and their approaches to task sharing in family planning and comprehensive abortion care area. So I would like to very warmly welcome all of us, especially a warm welcome to Professor Dilip Mavlankar, who is our collaborator from Indian Institute of Public Health, Dr. Bela Ganatra, who is our colleague from headquarters. She's heading sexual reproductive health, abortion in the sexual reproductive health department. Dr. Thomas Zapata, who is our colleague from WHO CERO, focusing on HRH, Human Resources for Health. And we also have with us Dr. Narun Nahar Rosi, who is Deputy Director and Program Manager, Quality Assurance, Clinical Contraceptive Service Delivery Program from Bangladesh, Ministry of Health, Bangladesh, and Dr. Bhim Singh Tinkari, Director of Family Welfare Division, Ministry of Health in Nepal. And this whole webinar will be moderated by my colleague who works in my team, Dr. Meera Upadhyay, who is Technical Officer for Sexual Reproductive Health. I'm Dr. Neena Raina. I'm the Senior Advisor for Maternal, Newborn, Child, Adolescent Health, Aging, Violence Against Women, and Midwifery. So, I would like to now hand over to Professor Dilip Mavlankar to tell us a bit more about IIPH, and then I'll hand it over later to Dr. Meera to moderate this session. Over to you, Professor Dilip.
Yeah. Good afternoon to everyone. First of all, let me thank World Health Organization Southeast Asia Regional Office and Dr. Neena Raina for this excellent collaborative effort on various topics related to maternal, child health, adolescent, and life course health webinar series on COVID and the health system various elements. we at Indian Institute of Public Health, which is the first public health university of India and a public health school where we offer Master of Public Health and Master of Hospital Administration postgraduate courses, as well as do a lot of research and health system support work, that we are very delighted to have so many people attend these regular Wednesday webinars on various topics. The topic of today is of special interest to me. I have also worked several years with the AMDD team on task shifting in maternal health, especially emergency obstetric care. So it is of personal interest to me also, this topic. And as Dr. Neena said, it is very topical because the whole health system is repurposed to fight this terrible pandemic of COVID. And we have to see how long will this continue and how do we balance the routine services along with the management of the pandemic. So it is a very challenging times, and we hope our eminent panel of experts from Geneva, from Delhi, from Bangladesh and Nepal, we will guide us on how do we do this tremendous task of task shifting so that we manage both the routine services as well as COVID and learn from each other's experience. With that, let me again thank and welcome all of you to this very interesting webinar series. Thank you.
Thank you very much, Dr. Professor Dilip Kumar, for your kind words, and we are very happy with this collaboration. Your team is excellent, and we are. It's not only the collaboration for arranging the webinar, but also our technical collaboration for your thoughtful ideas into the system. So with these words now, I think as Professor Dilip Kumar said, it's a very, very important area where we need to focus on task shifting, task sharing. We have with UNFPA and with UNICEF, did some mapping of services, service disruption, and we know that services are disrupted, especially during the lockdown period. There are both barrier and demand side factors which affect, and the health workers growingly, despite their best efforts and having been repurposed, we understand there is always a huge shortage for provision, providing essential services and also providing COVID. May I now hand it over to Dr. Meera to really take us through this webinar or to moderate this webinar. Over to you, Dr. Meera.
Thank you, Dr. Neena. Thank you so much. Good morning and good afternoon to everyone. Today, as Dr. Dilip said, and Dr. Neena also highlighted, this is one of the very important webinar that is very timely. And we know that there's lots of scarcity, and our eminent speakers and experts, they will be taking us through. The first speaker, Dr. Thomas, will be taking us through what is the global scenario on health workforce, and especially focus on SRM and CH and our region. And Dr. Bela will be taking us what does the WHO guidelines says about it, what are the alternatives, and how we can improve the access of the services. And thirdly, Bangladesh will share their experience, how they did it in family planning area, and the experience will be shared by Nepal to a special focus on abortion. So all these four speakers will really highlight on the need that we have always, and especially in this COVID period, how we are going to manage and how things will be in place, both essential services and other services. So having said this, I would request all the panelists to keep their mic on mute when you are not presenting. And I request all the participants, respected participants, to put their questions on the question box for after each presentation, and your questions will be shared by the respective panelists, and then they will be answering to your questions at the end of the session. So each session will be around 12 to 15 minutes. Then the time which is left after the presentation would be there with us for the discussion. So please remain with us till the end of the session so that we can discuss. So with this, I request Dr. Thomas to make his presentation regarding the human resource of health, available human resource of health. Thank you, Thomas. Please make your presentation.
Thank you very much, Mira. Thank you, Dr. Nina, and thank you, Professor Dilip. So, next slide, please. Next. So I'm going to give an overview of the health workforce situation in the Southeast Asia region. So initially, I'm going to give a background on changing needs, and then we're gonna go through the numbers, availability, distribution, skill mix, and performance and conclusions. Next. So let's start by the background. Next, please. So changing needs. We know that the health needs are changing over time. Next. So we know that, for example, aging population is aging. If we look at the Southeast Asia region, the population above 60 years old has multiplied by 3 from 2000 to 2030. So from 110 million in 2030, there will be 310 million population over 30 years old, and this has an impact on the way we organize and provide services. At the same time, we know that the overall burden of disease on non-communicable diseases is increasing for 40 to 60% from 2000 to 2015. We know that there has been an urbanization, an increase in urbanization from 32% to 41%. And then we have the unfinished MDG agenda, which includes communicable diseases, and of course, which is the topic of today, maternal, newborn, and child health services, which is still we have an unfinished agenda, and the system still has to provide quality service for patients. And then we have something new, which is COVID, which is really challenging the whole system, and is stressing and is stretching the human resources for health, and it represents also another challenge, and it requires that we reorganize the way we are providing health services. Next. So if we look at the if we look at the changes from an NCD perspective, for MCH and disease, infectious disease perspective into a non-communicable disease perspective, we have changes in the awareness. If you are sick or you are pregnant with a communicable disease, or you are pregnant, you know that you have something. On non-communicable diseases, people may be asymptomatic and they don't know. So that's a big change. Normally in communicable and maternal and child health, you have a short duration of the condition. However, in the non-communicable diseases, you have a long-term, probably lifetime issue. And then normally in communicable and infectious diseases, you have a single condition at once. However, in non-communicable diseases, we normally have multiple morbidities, multiple conditions at the same time. So then next, this means that we need to rethink the way we organize services to accommodate all these things. Next, please. It's taking some time. Yes. So then it means that we need to move from disease-specific focus approaches to more person-centric approaches, from more episodic focus approaches to more continuum of care, when we bring promotive, preventive, curative, rehabilitative, palliative care at all ages. From moving focusing only on equity on poor rural areas, now we also need to look at poor urban areas. We need to look at gender gaps, cultural barriers. So we need a more comprehensive vision. And then from focusing mainly on access, now we need to move and focus on access, but also important and very important on quality of services. And then before we were mainly focused on primary care, which we still need to be focused, but we also need to look at the linkages with other levels and hospital care. And then from a plan result based on budget, we need to focus on transition to a need-based approach. Next slide, please. So as I mentioned, we need to rethink the way we are providing services. So this slide trying to summarize all these linked to health workforce. So needs are changing. That will require health services to be adapted to be able to respond to those needs. And then in order to provide those services, we need to redefine the health workforce, and that shifting can play a critical role in how we align, how we provide services for these changing needs, in terms of the numbers we need, in terms of the skill mix, in terms of the competencies required, in terms of the new roles and the task shifting that I mentioned, in terms of the skill mix of the teams and the deployment. Next slide. And that will condition the way we train health workers and the way we train the future workforce. So let's focus on the situation in the Southeast Asia region. Next slide, please. So in terms of numbers and availability, I strongly recommend you. Last week, we launched in the regional committee the Decade for Health Workforce Strengthening report, the midterm review. We have a decade of 10 years for health workforce strengthening in the region, and now we are at the midpoint. So we have produced a report where we have the country profiles, HRH, Human Resources for Health, country profiles for the 11 countries in the region. So you will find all the indicators on the slides I'm presenting today. You will find it in this report that you can see here that is half page blue with the health workers in green, okay? And then we also produce case studies on rural retention that I also encourage you to see. Next slide, please. So countries are guided not only by these regional and global documents, but also by their health workforce strategies. And they are following that in order to adapt the health workforce to implement health services. Next slide. So the overall availability of health workers, as you can see in this slide, first message is that since 2014, doctors, nurses, and midwives have increased, the density has increased over time in all countries in the region. That's the first message. And then you can see that we had the previous threshold of 22.8 health workers, doctors, nurses, and midwives per 10,000 population. That one, now 9 countries out of 11 has surpassed that threshold. So it means that we only have 2 countries, Bangladesh and Myanmar, that have a lower density than 22.8. But that was the MDG target. Now in the SDG area, in the Global Strategy of Human Resources for Health 2016, we have a new target, which is the 44.5 doctor, nurses, and midwives per 10,000 population. That's the brown line. And as you can see, only 2 countries in the region have surpassed that threshold. So this means that we have done well over the past years, but we need to do better. We need to do more. Next slide, please. This is another way of representing it. Next slide. So if we look at specifically at nurses, because they play a key role in sexual and reproductive health and in task shifting, you can see also that there has been an increase in all countries over the time. You can see that India has reduced a little bit, but this is because we have better data. Before we were just relying on council data, but now we are relying on a live registry in the council, we are relying on other sources, and that's why we have better data. So that means that the density has gone down. But in general, the density of nurses in the region has also increased from 2014. Next slide, please. And if we look at the ratio of doctors and nurses, you see that the scenario is very diverse in the region. Bangladesh is the only country that has more doctors than nurses in the country. However, on the other side, we have Indonesia that has nearly 6 times more nurses than doctors. But the scenario is very diverse, as you can see. Next slide. And then some countries have introduced midwifery, and you know well that. So still midwifery represents a small proportion of the total nurses, but some countries are starting now to increase the number of midwives in the region. Next slide, please. Then, in overall speaking, we can say that doctors, they are mainly males, but the nursing doctors are increasing in most of the countries in the region. The nursing workforce is mainly female workforce, also the midwife workforce, and the dentists, we have and pharmacy, we have a diverse scenario. Next slide. In terms of aging, which is the next slide, what we know is that we have a very young, previous slide, please. We have a very young workforce in the region. If we look at the proportion of health workers who are over 55 years old, for nurses is only 6% in our region. However, globally is 17%. So we have to take advantage of this situation, because we have very few health workers, very few nurses that will retire in the next 10 years. And it's even better for doctors, because we have 10% over 55 years old in our region, but 34% in OECD countries. So we have a big dividend in this case. Next slide, please. So this year, for the first time, we included not only doctors, nurses, and midwives, we also look at other primary care workers like health assistants, which are really playing a critical role as mid-level providers and task shifting. So that's why I wanted to include this slide, even though data is still very partial, but in the next coming years, we will get much better data on this. Next slide, please. And we also included community healthcare workers. You can see here we have medical assistants, community healthcare workers, traditional medicine professionals, and paramedical. So we will get a better picture in the future, but what is important here is that we don't only focus on doctors and nurses and midwives, dentists and pharmacists, but we also bring other primary care workers who are playing a critical role in primary care to provide primary care services and reproductive and health services. Next slide, please. So let's get into the distribution next. So we see that it's also very diverse. It's difficult to get data on rural and urban distribution. We don't have that data yet. Most of the countries don't have. So what we did is get in the subnational level, and we see that countries like Sri Lanka, they have the difference between the provinces with the higher density and the provinces with the lowest density is much smaller. It's only 1.7 times. However, we have other countries like Thailand, when that difference is pretty big, or India, as you can see, is very uneven. Okay, next slide, please. And this is another way of visualizing by province, by country, the health workforce density. You can look at it in detail in the report that we produce. Next slide, please. And now, as I was saying, it was difficult to get data on urban, rural, also on gender gaps and cultural barriers. So we still need to work to improve data in these areas. Next slide, please. So in terms of, next slide, in terms of a skill mix, I think each country has to take its own decisions. Each country has to look at the distribution. Next slide, please. It's not coming. So each country has to look at the different contexts in terms of burden of disease, of budget, of power of different professions, and then trying to focus on patient-centered care and looking at the workload and looking at the national context in order to define the skill mix. There is not a silver or a magic bullet in order to define what is the right skill mix globally or in the region. Each country has to take its own decisions. And here is clearly important task shifting or task sharing in order to allocate competencies and tasks to the different professional categories. Next slide. So here is when you have to define what types of health workers. Next slide, please. I have 1 more minute, so I'm trying to go a little bit. This is a paper that we produce in the region on mid-level providers, mid-level health workers. So you have the link below, and we did a global review on the effectiveness of care of mid-level providers, which basically are those trained in fewer years than medical doctors, but they are performing the same functions and tasks as medical doctors. Next slide. And what we found is that mid-level providers, if well trained and supervised, they can provide care as effective as medical doctors. So I think this is an important message for this session on task shifting. They can reduce the cost in terms of training and in terms of salaries, and you can expand the scope of access, and also they can fill the gaps of shortage of certain professional categories. But they need to be well embedded in the system, well supervised, and well trained, and well paid as well. Next slide. And this is how Thailand, I think, is a good example how Thailand in the 80s started to really bet for nurses and increasing the number of nurses to provide primary care services. So basically they were doing task shifting in order for those nurses to provide needed services in primary care, while the doctors remain relatively flat. Now they are increasing the number of doctors in primary healthcare, but not at the time. Next slide. And I'm just getting into the final. Next slide. We can, next, please. And then we can skip this one. Next. Next slide. And then next, and then we get into the conclusions. So as conclusions, we can say that the health workforce has to adapt to the changing needs, to the demographic, to the changing burden of disease, and COVID is going to be critical as well at the moment. So we need to change and we need to adapt. In terms of numbers, in terms of distribution, is important for equity reasons to get people get the services they need. In terms of the skill mix, each country has to define what is the right skill mix, and thinking about the task sharing, and also in improving the quality of services and not only access. So I think I'm going to stop here. Thank you very much. Over to you.
Thanks, Thomas, for this wonderful presentation. This presentation has really highlighted the gap that we have and what we are going to have in future. Especially he also recommends for the time being for the immediate need, the immediate requirement that we need to have some kind of task sharing or skill mix of the health workers with skill mix capacities. So these are very important. So I request all the participants to jot down their questions for Thomas. So with this, thank you, Thomas. Now I'd like to request Dr. Bela she is the head of prevention of unsafe abortion, Department of Sexual and Reproductive Health and Research from HQ. She has been leading all abortion-related activities since many years in HQ. There are lots of publications from her, and she is very dedicated on this area of work. So I invite Dr. Bela to make a presentation on related to task sharing. Thank you.
Thank you, Mira, and thank you, Nina and Dr. Dilip. Can I have the next slide, please? What I'm going to do is just quickly run you through the global recommendations that we have on task sharing in the area of safe abortion and family planning. And none of these are new recommendations. These have been around for several years now, but unfortunately still we do not see many countries have adopted them in full, and the COVID pandemic actually gives us an opportunity to revisit the issue of task sharing and task shifting and optimization of the workforce. So the recommendations are contained in these three documents, all of which you can find on the WHO websites. The initial recommendations came out in an optimized MNH guideline, which addressed task sharing both for maternal health and family planning. Task sharing recommendations for abortion and post-abortion family planning were then updated in this guideline, which came out in 2016, called Health Worker Roles in Safe Abortion Care and Post-Abortion Contraception. The family planning recommendations themselves are also can be independently found summarized in this policy brief that you see on the screen. Next. Next, please. So it's important to note that all of the recommendations in the guideline are based on tasks and interventions that have already been recommended as safe and effective in WHO clinical guidelines. And they are really about a programmatic and planned and regulated expansion within a health systems context. They're not about specific, any individual trained in a particular task might be able to do it well, but the recommendations are meant for a regulated and planned expansion of provider base. The idea is to be inclusive for as broad a range of health workers as possible, and not to suggest that any particular cadre should be excluded from the provision of services. And again, this becomes very important when we're considering the COVID pandemic now, where different cadres are often repurposed to COVID, and we need a wider base on whom we can rely on to provide the SRH range of services. And though in part they do address the issues of health worker shortages that Dr. Thomas spoke about, it's also about a positive aspect in that often preferences for women may not be for the most specialized of providers. And we need to consider that many tasks and interventions in both abortion and family planning are simple and can very safely and effectively be provided by a range of workers that are not really specialist specific as well. Next. These guidelines were developed through a rigorous WHO guideline development process that includes at least a year of evidence review and synthesis. And just as an example, I'm showing you on this slide the evidence base that informed the safe abortion task sharing recommendations. And you can see that not only did we review studies and clinical trials that compared a range of health workers to physician providers in providing these services, we also looked at qualitative data and, most importantly, programmatic data from countries that have utilized task sharing approaches for a number of years. And of course, we're going to hear from Bangladesh and Nepal, who were two of the key countries that inform these guidelines in this seminar as well. So you can see that the evidence base is vast, developed from a lot of studies from many different contexts. Next. The WHO definition of a health worker is very broad-based and includes everyone who's engaged in the idea of enhancing health. So with that in mind, these guidelines also look at a wide variety of health providers, ranging from what you see on the right-hand side of your screen, the specialist doctors, all the way down to recognizing that women themselves, the users, have a role to play in their own health and in the management of safe abortion and family planning. So the entire gamut is covered. Of particular interest to this region is that we covered also the role of the specific cadre of complementary medicine doctors, which are a large group of practitioners within the CR region as well. Next. So here it's showing you diagrammatically the types of interventions that were found to be safe, effective, and appropriate for different cadres of providers to do. If you see a solid green tick, that means that these are cadres who could provide these services safely and effectively without really any concerns. If you see a dotted green tick, it suggests that this intervention should be done within the context of monitoring, evaluation, and specific caveats related to the service provision. And the red crosses mean that this is not appropriate for that particular cadre. And the little yellow with R suggests that this is promising, but at this point it still needs to be done in a sort of research context before we can move further to scaling up to programs. So if you look at this table, which is about abortion care in the first trimester, we see that in the surgical vacuum aspiration, most providers who are present at primary healthcare facilities, nurses, midwives, non-specialist providers, are all considered fine to provide these services. As we move to medical methods of provision and the use of medical abortion drugs, again, more and more important in the COVID pandemic, we can move lower down the health system, and even auxiliary nurse midwives are considered appropriate to provide these services. For certain other cadres, like pharmacists, we didn't think that we had evidence to suggest that they could actually provide the entire service, but that doesn't mean that they can't be involved in service provision. So next. You can see that we've still recommended that they can be involved in various pieces of service provision right now in a research context. But most importantly, next please, they have even now a very critical role to play in the provision of information and counseling, if not the entire provision of services. So it's really not black and white, yes or no. Almost every cadre of healthcare worker does have a specific role to play within the overall continuum or spectrum of care for the service. Next, please. As we move to talking about care in later pregnancy and in the second trimester, we talk about more limited options for expansion of provider base and restriction of services often to specialist and non-specialist providers. And that is partly due, at least at the time of making of these guidelines, the lack of studies and programmatic evidence that looked into these aspects. I suspect that there is much more now, and in fact, the task sharing recommendations are currently under review and will be updated next year, and we might find that some of these evidence gaps might have been filled by then. Next. In the range of family planning again, an entire range of health workers, from community-based workers upwards, can provide information, counseling, condoms, emergency contraception, and oral contraception. As we move to more use provider intervention type of methods, we find that we need to go to more qualified providers, but still a vast range of primary care level providers can provide a range of family planning methods, including injectable contraception, implants, and IUDs. Next. These task sharing guidelines also considered a very important component in current day COVID context is that of recognizing the role of sharing some of the tasks of care provision with the women themselves. And in this context, where women do have access to backup care and the appropriate information and quality medications, the guidelines already suggest that women can manage the process of mifepristone and misoprostol outside of a health facility and outside of direct supervision of a healthcare provider, and can manage the issues of follow-up also on their own. It also makes a recommendation that self-injectable of contraceptives is an additional option for program management. And I think as we move towards looking at options where facility visits are minimized and contacts with scarce providers are also lessened, we really must give great importance to this idea of self-management and develop the tools and approaches like telemedicine that can support successful self-management. Next. And so clearly these task sharing recommendations have a lot that is required to move them from being recommendations to being actually programmatic reality. And in the 4 years since the guidelines have been in existence, there's been mixed success globally in terms of adaptation and use of these recommendations, but certainly Bangladesh and Nepal are, of course, two major success stories. And so we'll wait to hear more about implementation in their contexts. Thank you.
Thank you, Dr. Bela. Thank you for your presentation. You have really taken us through not only through the task sharing and task shifting guideline. You have also showed us some part of self management guidelines also, and then you have also touched upon some digital health innovations which can be utilized during this COVID time. So with this, again, I remind my dear participants to put your questions to write down your questions for Dr. Bela, which we will be discussing later on after we finish all 4 presentations. So thank you, Dr. Bela. Thank you, all participants. So now I request Madam Dr. Nurul Nahar Rosi. She is the Deputy Director and Program Manager of Clinical Contraceptive Service Delivery Program in Director General Family Planning Office, Ministry of Health, Bangladesh. So Madam will be presenting the example how they have worked in family planning area with this task sharing and task shifting modalities. So the floor is yours, Madam Dr. Nurul Nahar. Thank you so much. Thanks. Please start your presentation. Thanks. Madam, please kindly unmute yourself. Madam, unmute yourself. We can't hear you. Dr. Narun, we can't hear you. Kalpana, can you unmute Dr. Narun?
Dr. Meera, we have checked it. Actually, Dr. Nurun, can you just unplug your audio system and just directly speak from your laptop? Can you check that?
May I suggest while we are setting up and getting Dr. Nuran to really check her system, in the interest of time, can we move to Dr. Tenkari?
Yeah, sure.
Yes, ma'am. Yes, sure. Thanks, ma'am. So I request till Dr. Nurul's mic gets fixed, I request Dr. Tinkari. He is the Director of Family Welfare Division, Department of Health Service, Nepal. He would present on the experience of task sharing in comprehensive abortion care in Nepal. Dr. Tinkari, can you start your presentation? Thank you, sir.
Hello. কেন আমারটা কি বাদ?
Yeah, Dr. Nurun, we can hear you now. Yes.
Okay, thank you, ma'am.
Dr. Nurul, can you go after Nepal? Because I've already asked Dr. Tinkari to start.
Okay. It's okay.
Okay, thanks. Dr. Tinkari, please.
Good afternoon, everyone. Dr. Nina and all the delegates from the different part of the world. Can you hear me?
Yes,
sir,
we can
yes.
hear you.
Yes. So I'm going to make presentation of the task sharing and task shifting, what we are practicing in the Nepal for the last 13 years. And can you go to the next slide? So far as international commitment and national commitment, and what the Sustainable Development Goal has said that we have to reduce the maternal mortality to 70 by per 100,000 life birth by the SDG era 2030. And family planning is a deployment agenda and access to the family planning service to all eligible couple. And another is to eliminate the gender-based violence and increase the investment of family planning by 7% as we have committed in FP 2020. Next slide, please. So far, policy document is concerned, I have already mentioned that we have set the target of SDG to reduce the maternal mortality. This all health SDG are set in the goal 3, and reducing maternal mortality. I have already mentioned that, and these all are. Previous slide. Yeah. So far, we have endorsed the Safe Motherhood and Reproductive Health Act, which says the we have established safe abortion and family planning service are priority for in that act also. And this has also next please. And increasing investment on the government side by 7% is our priority, and every year we are increasing, and we are following this FP 2020 movement for last 5 years. So far, the status of women is concerned, the literacy rate is around 57%, and our total fertility is 2.33. Currently, our maternal mortality rate as per NDHS 2016 is 239 per 100,000 live birth, and our contraceptive prevalence rate, including modern and traditional method, is 52%, and for modern it is 47%. Still, we have a high unmet need, is around 24%. Next, please. So far, abortion is concerned. It is legalized in Nepal for the last so many years, and when you look at the abortion services, only 42% is legal abortion. The rest at clandestine illegal abortion is being carried out in the different areas of the country. So we have to focus on the this clandestine or illegal abortion. So in order to avoid the maternal mortality rate, because it contributes around 6 to 7% of the maternal death. Next, please. As per the data of 2014, around 233,000 abortions were carried out, estimated cases abortion, and out of that, I have already mentioned that 58% is illegal abortion, and out of that, 80,000 women were treated for the abortion-related complication, and 68% of these complications were due to the illegal abortion, and 8 out of 100 women of childbearing age are treated for the abortion-related complication, and I have mentioned that it contributes around 6 to 7% of maternal death. So, in order to reduce the maternal death, we have to focus on the abortion services too. Next, please. So, task sharing and task shifting is concerned. Initially, we used to spell out task shifting, but it has to be now it has changed to task sharing. And this has been started in 2002, and still till now it is continued. It's going on. initially when we are talking about the task shifting, there are many objections from the different organization that this should not be done. So because of our population, our geography, the task sharing and shifting is really important for Nepal. And so far, the abortion service is concerned, it was legalized in 2002, and the task sharing was started as a WHO guideline, as Dr. Bella has presented. We have followed WHO guideline, and for 2016 we have started CAC service by staff nurse, that is a comprehensive abortion care by staff nurse. And in 2008 we have started registering this MA drugs in the DDR, and in 2009 we have introduced the MA medical abortion, and SP were 10 A&M, and were provided training, and they were carrying this medical abortion services. And so far as we have a national SARS guideline, MA drug and equipment supply. And I have already mentioned that Safe Motherhood and Reproductive Health Act has already endorsed in Nepal, and abortion and family planning service is established as a right. No one will be left behind for the services, and service provision without the discrimination is the key points that Act really speaks. And we have also introduced, as per our constitution, we have also introduced this basic health service, includes safe abortion and family planning service, because we have developed a package as per that is the right of our constitution is mandated, and that is the right of every woman. And safe abortion and family planning is also included in the basic health service package. Next, please. So far, I mentioned that abortion is the right of women, and we have you can just see in the slide, trimester first up to 9 weeks, up to 12 weeks, and beyond 12 weeks is the second trimester. And method up to 9 weeks we are using medical abortion, and up to 12 weeks we are MBA, and at more than 12 weeks DNC and medical abortion. So task shifting up to 9 weeks, this we have a auxiliary midwife, staff nurse, MBBS, OBGYN they can carry out. And for up to 12 weeks, only the trained A&M but not allowed, staff nurse only up to 8 weeks, and MBBS and OBGYN up to 12 weeks. And trained OBGYN and MBG are working in the public, NGO, and private sectors. And where we do this, provide this abortion service, we have a registered safe abortion service SARS facility in the different area. They must be registered. So all the SARS facilities has to be registered in the Department of Health Service Family Division. But now the country has gone to a federal context, so we are planning to decentralize all this registration facility. As training, everything we are planning to decentralize, and the action plan has been already endorsed with the help of WHO. And this we have still have to consultation with the provincial government, because of COVID facility we are not able to carry out these dialogues. So once the COVID is over, we'll be accelerating our work. Next. So training requirement is mandatory for all, even the specialist MD, GP, OBGYN, training is a must. We have to, they have to get the training for providing these all abortion services. So OBGYN is 3 days, physician only, MBBS it's 10 days, staff nurse 14 days, NM for the medical abortion only is 5 days. They are not allowed to do MBA. This is our training requirement. Next, please. So I mentioned that even the specialized doctors are there, OBGYN is there. Training is mandatory for all to provide this abortion service, and that has to be as per the NSTC guideline. And it is mandatory that the facility must be registered for the providing abortion services. So we are using the special checklist for the supervision monitoring by Department of Health Service, if the provincial director, district health offices, or even the partners, they are continuously monitoring, and we are using the special checklist for that. So we are continuously following, and we are trying to maintain the quality assurance of the service being provided. Next, please. So far, family planning is concerned as per our NDSS 2006 is our modern contraceptive state of modern method is around 43, and we have set the target of 60 by 2030. And still, I mentioned that unmet need is still high, and it's around 24%, and there is geographical variation between mountain, hill, and terrain. So we have tried to do this. Even the adolescent fertility rate is very high. Contraceptive unmet need is also high in adolescent. So we are already prepared the mapping of the areas where these unmet need for the adolescent is high, and we will be planning based on that mapping. And we have already completed that one. Next, please. So for post-abortion contraceptive is concerned, we are providing this IUCD implant, depot, OCP, condom, and male and female sterilization. These are the common methods. We all are aware of that, and for based on their choice, we provide this post-abortion contraceptive devices. Next, please. For providing a post-abortion family planning service, also this. Do you previous slide, please? Yeah, training requirement is mandatory, and you can just see that for OBGYN, ICD implant is 3 days, physician 5 days, staff net 8 days, and for A&M it's 8 days. These are the training requirement, and that is a mandatory. Yeah. The same thing I have already told us, and the quality assurance is really important for family planning beside this abortion care, and training is mandatory for all, and checklist is being used by the different level for the continuous monitoring to assure the quality. Next, please. So far, post-abortion family planning in Nepal is concerned when you compare with the 2017-18 with the 2016-17. In 2016-17 is around 70%, but 2017-18 is 75%. It increased by around 5%. So when you look at this methods being used, long method or short method, long-acting methods are is around 52%, and large method is still very low. It's around 17%, and we are focusing on the large. We are trying to focus on the large method to be introduced in the post-abortion family planning, so we can increase our CPR and reduce the unmet need. Next, please. So place of abortion, when you talk about the place of abortion, it is mostly public facilities, and the private sector is also contributing for that, and those private sector who want to provide this post-abortion family planning service or abortion service, they must be registered, and site has to be registered. Every service provider has to register, and that is mandatory for private sector also and NGO also. Yeah. So far, the role of professional societies are concerned in the task system in Nepal is that we have a different organization. Let's hope we have nursing association, we have midwifery association, we have medical association, and they are always involved in the technical working group, engaged in training, and as a trainer, they are also involved in coaching and mentoring, and also providing support to the development of different package and the guideline. They are continuously supporting on that. So far, challenges are concerned. Challenge or first challenge, strengthening health service delivery in Nepal in federal context is really challenging for us, because countries has moved to federal context, and we have 750 local government and across 7 provincial governments. So we have to empower provinces and local government to regulate the quality of health service, expanding service provider base and registration of facility. I have already mentioned. We are planning to decentralize all the training facilities to be decentralized, and restriction of facility to be decentralized to the provincial, if possible, to the local government also. And second thing is ensuring the availability of quality drug. MA drug is our challenge, because initially we used to procure from the central federal level, from the federal level, and used to supply to the district. From district, we used to go to the service delivery point. And for last year, we have allocating budget to the local level. So in some local level, they couldn't procure because of the procure. That's one of the issue, challenge. And ensuring quality is also equally important for that. So partners are also supporting on that, and we have also made assessment about the availability of this MA drug in the district. So when you look at the district, they stock out in some places. When we have also made assessment at the service delivery point. So far it is concerned in service delivery point, there is no stock out in the most of the facilities. And regarding this abortion service and family planning, including sexual reproductive health, strengthening pre-service education is also important. And we have reviewed all the medical curriculum of the medical colleges, how that has been addressed. And after assessment, we'll be piloting the 5 institutions we'll put in the curriculum, and that ready-made product will be there, so that they will know that we might not need additional training for that. And we are another is evidence-based planning and forecasting is actually quite important, because of the fertilization, we have to get report from all the local palikas. So we don't have the human resource in all these palikas. So we are having continuous training and mentoring. We are doing. So the reporting system is slightly disturbed. So strengthening SMS and LMS is very important for us, and it might take some time to improve. And awareness is equally important, and we have already developed national communication strategy on all the communication strategy that will help to increase the awareness among all the users. Next, please. And in conclusion, what I want to say, task sharing is the improvement strategy, and Nepal has been implementing this for the last 13 years. And even in this COVID situation, initially the service delivery was slightly hampered, and we have introduced the interim guideline. We have instructed, we have provided PP, and that is whatever service are being provided. We have made a rapid assessment in the when COVID started, and after 4 months again we done the second rapid assessment. When we compare with the data, it has improved, and service delivery is being carried out. Even the family planning as well as abortion service, including ANC, PNC, and other services, OPD is quite improved even in the COVID situation. And medical abortion is preferred method, and is opted by the 72% of women as per our NDHA 2016. Trained ANM staff nurse, medical officer are providing the post-abortion family planning service in Nepal. Post-abortion contraceptive uptake increase, I already mentioned, in 2016-17 is 70%, and 2017-18 is 75%. So post-abortion contraceptive among the MA users are 82% compared to the surgical method. So post-medical abortion, those who are taking the medical abortion, the contraceptive, post-abortion contraceptive is higher as compared to the surgical method. Next, please. Thank you.
Can you just make it very short? Yeah,
okay. Just last slide. And besides this task shifting the abortion service and family planning service, we have also task shifting with the rural ultrasound services for screening the pregnant mother in different areas, and delivery of a long-acting method through the visiting service providers. That is also one of the example of task shifting. That's all. Next slide. Thank you very much.
Thank you, Dr. Tinkari. Thank you so much. Thank you on sharing all the evidences you have on tax sharing in family abortion services, and there are lots of things happening in abortion in Nepal, and basically we take it as example in some part of it. So saying this again, I request my participants to put the questions to Dr. Tinkari if you want to know anything in detail. So thank you, sir. Thank you once again. So I request Dr. Narur Nahar. Madam, is your audio set up now? Dr. Narur Nahar. Yes.
Yes.
Okay.
Can you hear me?
Yes, we can hear you. Thank you. Thank you for your understanding, ma'am. Please put your video on also.
Yeah.
Thank you, madam. Please start presentation. Thank you.
Yeah. Assalamu alaikum, ladies and gentlemen. Good afternoon. Distinguished panelists, learned audience. Greetings from Director General of Family Planning of Bangladesh. And now I am going to our experience about task sharing on family planning. Next slide, please. I present some discussion point here. Overview of service delivery and background of task sharing, current country context, learning, and way forward. Next. I would like to share the country health service delivery system. Mainly two streams are working for service delivery, that is Director General of Family Planning and Director General of Health Service. Infrastructure exists from national level to the community level. Moreover, there is some additional directorate working under Ministry of Health and Family Welfare, like Director General of Medical Education, Director General of Nursing and Midwife, NIPORT for training and research, NGOs and INGOs, and some private sector, formal and non-formal, are simultaneously working with the Ministry of Health and Family Welfare for health service delivery and family welfare service also. Next slide. Here, our services from Director General of Family Planning. I want to share some background here. Bangladesh Family Planning Program evolved through a series of development that took place during the last 52 years. Family planning efforts in this country began in the early 1950s with voluntary effort of a group of social and medical workers. Categorical family planning program emerged during 1965 to 1995 with the objective to control population growth as a strategy of economic development. Then 1985 to 1990, a broad-based, multidisciplinary, multi-dimensional, intensive MCI-based family planning program was launched. Then 1990 to 1995, MCI's AP-based service delivery with enhanced quality of care expanded. Currently, family planning program in Bangladesh has been implemented with aim of to reduce total fertility rate, to increase contraceptive prevalence rate, to reduce maternal mortality rate, child and infant mortality rate, like this. These are the operational plan of DGFP capturing the service approaches, 3 operational plan, clinical contraception service delivery program, then field service delivery program, and MCI delivery program. These are service unit and other are support unit. And now I want to share why task sharing in family planning. Bangladesh has achieved success in the family planning program against the background of low literacy rate, low status of women, low income, etc. high population is still remain as one of the most important national problem. Considering the fact government committed to meet 75% of the global demand for contraception by 2030 to reach the SDG target. To reach this goal, AP service object is to meet the client demand by availability of trained health provider, uninterrupted supply of commodities, improve quality of service provision, social and behavior change, gender rights and perspective, etc. Next. But there is certain gap, so task sharing is moderately mandatory to reach our global and national target. In current context, next, we also realize the need of benefit of task sharing, and especially during this period, we emphasize the need of task sharing for COVID-19 crisis and person with disabilities. Next. Where and when task sharing initiated? Our task sharing is in we categorize in two types within the health facility and with supply output. Within the health facility, under this type of task sharing, responsibilities are delegated to lower level providers within a facility. This type of task sharing is extremely useful in reducing routine tasks of the physician and high level providers. Like this MR, PAC service, then injectable service, these are provided by paramedics, and especially long-acting reversible method like implant and tubectomy NSB provided by only for doctor. And we know about with supply outlet, there are we share that community health worker and other providers perform some tasks that clinic-based physician and paramedics are provided. Here in the remote location, this type of task sharing can bring service closer to women who would otherwise have to target long distance. Travel time for client could be estimated by domiciliary service by the community health workers, and thereby uptake and continue contraceptive use if facilitated. In Bangladesh, under this type of task sharing initiative, injectable contraceptive provided by the family welfare assistant at the doorstep, and community skill birth attendants are conducting normal vaginal deliveries at the community level. Here, series of work, I mentioned some here. 2012, Ministry of Health and Family Welfare issued government order to introduce family planning service by nurse midwife in selected pilot area. Next, 2014, Ministry of Health and Family Welfare issued GO government order for nurses to provide MR service, post-abortion care service, and family planning services, and include in their job description. Then 2016, government order for counseling for family planning, postpartum family planning at Director General of Health Service and Director General of Family Planning Service as to their service delivery point during ANC, post PNC, delivery time and EPI session also. Another circular allow FWA community health provider, NGO provider for injectables, and another circular for work on SOP for midwife developed and included family planning service to their job description. Then 2017, government order from DGFP to introduce postpartum family planning training for doctors, nurse, midwives, paramedics, and NGO providers. And then 2018 include midwives for offering family planning service, MR and PAC service, and post MR and PAC family planning service for midwives. Next, please. Some milestone on task sharing, inclusion of MR PAC and family planning service in the nurses Job description 2014 I mentioned here, previously, and here the NTC meeting minutes. Next, please. Some another inclusion for nurse services, another order. Next, please. GO for counseling for postpartum family planning at 2 Director General during ANC, PNC, PI session. This is the circular. Then next, and another GO from DGFP to introduce postpartum family planning training for doctors, nurse, midwives, paramedics, NGO providers. These all are addressing the tertiary, there are addressing of milestone. Next, please. Next, please. Here I mentioned currently healthcare providers, including like OB/GYN, general practitioner, nurses, midwives, community health workers, are offering family planning services and methods. Next. Here our country experience. That is 1975, we here see TFR was 6.3 and CPR was 8%. Now currently CPR is increasing to 62% last BDSS in 2017, and TFR also decreases. Thank you. Next. Distribution of modern methods by source of supply. This is a pie chart from BDSS 2017-18. Here we see NGO sector provide 4.6% of supply source of family planning. Then others providers, other private source 1.2%, and public sector supply 44.4%. And here specially mentioned private medical sector 49.3%. I want to share among these private medical sector, pharmacy, drug stores serving 44.1% of users. And another important point, till now, private medical college, private clinic and hospital are not ready for providing family planning service. About 75% of private facility are now not providing family planning service. Please, next. Bangladesh now strategy to public-private partnership for family planning in services. Here some mentioned. Here I mentioned some important milestone, like sign of MOU with DGFP with private medical college hospital to ensure contraceptive supply and family planning services. DGFP also signed MOU with Bangladesh Garment Manufacturers and Export Association and Bangladesh Knitwear Manufacturers and Export Association to ensure family planning services from factory clinics. Another social marketing company offering several forms of contraceptive service, including long-acting reversible contraceptive through Pink service provider by doctors and specialists, and Blue Star providers, pharmacy man supply short-acting method with injectables. Here last one is production of public-private partnership model. Currently, private sector provide 51.3% of contraceptives and 48.7% comes from public sector. Next. I want to share some picture. Nurses participate in the postpartum IUD training in first picture. Then another picture, government provider providing implant and tubectomy. Of course, they are doctor at sub-district level. And here Blue Star provider, SMC provide short-acting methods and injectables, and LA long-acting reversible contraceptive and permanent method. Clients are referred from this Blue Star provider. They are after train, they provide the services. Next, please. During COVID, we address some task sharing with family which are related with family planning service. Our country peak April 2021 onwards is COVID-19 and lockdown initiate 26 March 2020. After initially services are very much lower, but as soon as possible, we our Ministry of Health and Family Welfare level, they inform task force, and then different committee formed at divisional level, district level, sub-district level to continue the field level implementation of family planning and as well as health service. And national guidelines, some guidelines were developed infection prevention control guideline, virtual orientation to the service providers, then introduce digital supportive supervision, different and many webinars informed by Obstetrics and Gynecological Society of Bangladesh to update service providers' knowledge on COVID-19, on maternal, child, reproductive and adolescent health. OB/GYN circulate their cell numbers to provide for teleconsultancy on antenatal care, postnatal care, family planning services, help to continue long-acting and reversible contraceptive permanent method services during COVID-19, and they also ensure referral. Our tele-counseling hotline 16767 Shukhi Poribar, Healthy Family, by information, education and management of DGFP, one directorate. They support 24/7 for counseling service on family planning and maternal, child, reproductive, adolescent health, and they also refer the client to the nearest center. We increase distribution of pill and condom to the user for an expanded duration. Like previously, we supplied 2 months for pill and condom, and during COVID, we give a circular for 4 or 5 months. They give the condom and pills. We introduce regular long-acting reversible contraceptive and permanent method service with proper precaution. We initiated depot holder system at the community level for expand the access, allow community health service provider for contraceptive distribution, accessibility of short-acting method to near catchment area by private pharmacies. We also utilize workforce for MR and PAC service and also post-MR and PAC family planning services. Next, please. But till now, some challenges for task sharing, and of course, COVID-19. We have strong commitment needed for task sharing despite the high number of vacancies. Our absence of task sharing, task shifting strategy, capacity development of other cadres also one of the challenge, lack of data for evidence-based advocacy, lack of continuous mentoring and post-training follow-up. We have inadequate coordination between Director General of Health Service, Family Planning, and Director General of Nurse Midwives. Inadequate joint monitoring also, which is also challenges. We have lack of appreciation for best practices and adaptation after post-COVID-19 situation for new normal life. It also our challenges. Next. Next. We think some way forward to achieve national and global target need to increase long-acting reversible contraceptive and permanent methods uptake by utilize the service providers. We engage more OBGYN for long-acting and reversible contraceptive and permanent methods. We engage more midwives for postpartum family planning. We utilize more frontline provider like health assistant, community health service provider, family welfare assistant, skilled birth attendants for injectables, for oral pills, for condoms, etc. We utilize more the NGO providers and private practitioners, undergraduate doctors for IUD and injectables and other implant service also. We want to strengthen partnership, NGO, private sector, profit and non-profit organization to increase share by increase investment for commodities production like oral pill, condom, implant. Then here only condom and oral pill are produced in our country, but we want to injectable one company production is injectable also, but now we thinking about implant and IUD production in our country, and also we want to increase our supply sale in open market. We think marketing to increase demand and to decrease stigma about family planning different methods. We engage NGO network to increase access at health facility level after COVID-19 and also strengthen our network. We encourage public-private partnership model to ensure contraceptive security. Next, please. And that's all. Thank you for patient hearing. Thank you, everyone.
Thank you. Thank you, Dr. Nurul. Thank you. Thank you for this wonderful presentation, which doesn't only talk about task sharing. It actually takes us through the whole process which Bangladesh has taken to implement the WHO guidelines, especially task sharing in family planning sector. And it's not only about the services and health workforce. You also shared about ensuring the supply chain management inside your country. So this is a wonderful example for us. Thank you very much, ma'am. So with this,
Thank you so much.
Thank you, ma'am. With this, the presentation from our eminent speakers, panelists, experts is over. So we will have a very short question and answer session now. So I will just pick up some questions because due to the time limit we have, I'll just pick up a few questions. And I request we will be sending you answers through the mail later for all the questions. So with this, I would first I will start the questions to Thomas. It is actually not related to task sharing, but it is related to midwifery. So the question was from one of the participants. He or she is asking, can increase in number of midwives will reduce the maternal mortality rate, infant mortality rate, and increase the access of services? So that was the question from one of the participants, Dr. Thomas.
Thank you, Dr. Mira. I think overall speaking, we have evidence that increasing the health workforce, increasing doctors, nurses, and midwives, we get better health outcomes and we increase life expectancy. We have that evidence. We also have evidence that from the last commission on midwifery, that increasing nurses also improves the health outcomes in maternal and child health outcomes. What I think is important to consider is that we need to increase the numbers, but it's not only about that. I think it's also important about improving the quality of education, is important about improving the organization of services, having enough the right equipment, having a good supervision, good management system, appropriately paid and incentives. So I think it has to be a conjunction of everything so that we allow that midwives are providing quality care, which I think is the critical element in order to improve health outcomes. So I think it's a combination of all those things. Over.
Thank you, Dr. Thomas. Now I'll go to Dr. Tinkari. So there is one question related to COVID crisis. So the question states that there has been a disruption in the health services in Nepal due to COVID-19 crisis. What was the approaches taken by the government to increase the access to MA services to the women who need them? Dr. Tinkari, please. So kindly unmute yourself. We can't hear you. Please unmute yourself.
Okay, thank you, Dr. Meera, for your concern. I have already mentioned that initially when COVID started, most of the services concentration was on the COVID, and non-COVID activities were not much taken seriously. And I mentioned that we made the initial rapid assessment with the help of UNFPA, and most of the non-COVID services were interpreted in different health facilities. That was the digital interview is being carried out. And after that, Ministry of Health endorsed interim guideline, and why not COVID is one component. Why not to focus on the other component? Because of the other if you don't focus on other death, only the COVID death when you count is around 200. Because of other conditions, many mothers, many children are dying, so we have to focus on that. And we did the second rapid assessment, and we compared this first when COVID started and second rapid assessment after our intervention, different training and ensuring logistic at the different areas. We did the assessment, and all the non-COVID services, including the MA service, has improved. And in last year's webinar also I presented that what the status of abortion service before COVID, after COVID, or last year's the same period. And that is that is in that slide also. And if you want to, and we expect that not all 100% women who really want MA service, they are not getting it because still COVID is in the community transmission. So we are trying our best to advocate with all the local level. This is also equally important for the mothers. So we can share that slide also, and we also compare the SMS of last previous year and this year. And that is not around 70% services they are getting. That's the data we can share. Thank you.
Thank you, sir. To dear panelists, I will place all the questions in email. And kindly request you to give answers in bullets so that I can share with all the participants. Thank you, the participants, for being here. So now I hand over this floor to Dr. Nina Rena to have closing remarks for this webinar. So thank you all. Thank you for wonderful presentations, and thank you for all the participants. Still now we have 266 with us. Thank you very much. Thanks. Over to you, Madam Dr. Nina.
This is thank you very much. This is a very informative webinar. I think I gathered 3 messages out of it. One is with the changing needs in the countries, with the growing population of aging, non-communicable diseases, And some of the other burden, magnitude of communicable diseases and maternal and newborn and child mortality continuing, our aging population, as well as there are countries where the young population or adolescents are also increasing. So we need to really change and improve our health workforce numbers, their distribution, their skill mix, and performance. And I think this just by doing task sharing or task shifting is not enough. It is very, very important that these skills are maintained. I remember a long time back when we thought of, when institutional deliveries are not were not very good. Most of the deliveries were conducted by traditional birth attendants. We thought of training them in resuscitation. I'm talking of 1983, 84. But then the real challenge was if they are not going to see even one asphyxiated case in 1 year, they'll lose those skills. So I think when we think of task sharing, task shifting, uh, skill mix, use of skill so that they have enough numbers to be able to practice, and also monitoring and mentoring and excellent referral linkages. We may bring down these skills to the relatively younger, or I would say primary healthcare workers level, uh, which is ANMs, nurses, midwives. But then if they do not have good referral linkages to be able to refer timely some of the cases which they are not able to manage, I think our purpose will be not solved. Second important point I would like to highlight is professional associations have a major role to play. At times I've seen that some countries who thought of task sharing, task shifting in other areas, not necessarily abortion area or family planning area, there was a lot of resistance and protests from many of the professional associations and the doctors, and they didn't want those to be given to the paramedical workers, some of the things, some of the the skills or jobs to be done by relatively different cadre of healthcare providers. So professional associations have a big role to support such decisions and also build skills and train such cadre of people who can provide and contribute to this whole process. I would my last point is that task sharing it's a proven strategy. There is enough evidence. Dr. Bela has also shared. Dr. Tinkari and Dr. Rosie clearly mentioned that they have been in it for a very long time. Nepal has been doing for 13 years, and we have seen the results in terms of mortality reduction, in terms of increase in coverage of services. If task sharing also leads to giving closer access to the communities for the services for which they don't have to travel miles and miles away to get necessarily to a specialist, and the burden of specialists also increases. And there are enough number of studies and estimates to tell us that every country there's a huge gap of specialists. So COVID has taught us one thing. Ventilators are there, but we don't have people who can operate those ventilators. Countries which really trained their medical officers or just medical graduates in resuscitation and managing critical care or anesthesia, giving anesthesia during surgeries, are relatively still been able to manage these critical cases better. So I think equipment alone doesn't mean we need more specialists. We need more people who are trained in providing care so that the coverage of services improves. So I think this has been very, very interesting webinar for us. This is not the end of sharing experiences. We'll be also planning more webinars around this area of work. And with these words, I would like to thank all the panelists, Dr. Thomas, Dr. Tenkari, Dr. Rosie, and Dr. Bela, for really giving us some deeper insights. Evidence is there, we have to implement it. We have to take action. And that's where I think it's very, very important for us to start moving forward. Countries have done wonders, and they will continue to do wonders, in this area of work. If we want to save mothers, to even some countries, 16% of contribution to, maternal mortality is coming from abortions. And family planning, I think unwanted pregnancies, if we can avoid, we can also avoid, unwanted or clandestine abortions in a big way. So I'd like to thank all the panelists. I'd also like to thank the participants who have connected and stayed with us for this long. I remember the highest number I recorded was 327, which is very good participation in this webinar. And I'll also like to thank Professor Dilip Kumar and his team, who has really worked seamlessly and made sure that there are no hiccups in the whole process. And I'll also express my thanks to my team member, Dr. Meera, for moderating this session. With this, I think the key messages we have to take home. We'll be sharing the PDF files of the presentations with the participants who have attended. We'll also be sharing, we'll try and see how we can document all these webinars together in the form of a report so that everyone can access from our website. Thank you very much once again. With these words, I'd like to, close this webinar and have a nice day ahead of all of us. Okay. Bye-bye.
Thank you. Bye.
Thank you. Thank you, Bella. Thank you, Dr.
Thank you,
Tenkari.
Dr. Nina. Thank you. Bye.
Thank you, Dr. Thomas, for staying on with us. Thank you to Professor Dilip Kumar.
Yeah, thank you.
And
Thank you.
Meera, well
Bye.
done. Meera, keep it up. Well done. Thank you.
Thank you.
Thank you. Bye-bye.